essentially medications, oral medications, that are used for nerve pain. So nerve pain is that burning, lancinating, stinging, hot pain that people complain of. Different than the musculoskeletal pain, different than muscle spasm pain. And any of you in the audience that experience that type of pain know exactly what I'm talking about. So there's specific medications that help with that type of pain. And they include medications like gabapentin or Neurontin, which you may have heard or had a familiarity with. There's also other anti-seizure medications that are used excellently for anti-neuropathic pain therapies.
So you don't have to have a seizure problem to be put on that. It's just that also a pain medication.
Exactly. Exactly. So these anti-seizure medications help reduce the impulses of the nerve pain in the body, just like they would help reduce the impulses of pain in the brain, essentially, that people with epilepsy experience. Non-narcotic, non-opiate, non-addictive, very effective. Antidepressants. So your first question is probably, I'm not depressed, and even if I am depressed, my pain is not all in my head. So why do you want to give me an antidepressant for my pain? Well, we did talk about briefly how when you're depressed and you have no energy to do anything, you have no energy to eat, you have little energy to breathe, you have no energy to manage your pain. So really focusing on improving your mood, and sometimes that requires the use of an antidepressant so that you feel like getting out of bed, you feel like doing your stretching exercises, you feel like going for a walk, you feel empowered to be able to manage your pain just like you manage your chronic disease. There are specific antidepressants also that have indications for chronic neuropathic pain. So medications such as Cymbalta, Savella. These are medications that you may be familiar with as being used to treat fibromyalgia, which is a chronic myofascial nerve pain disease. So these medications are very powerful, very effective, and they really can, to coin a phrase, kill two birds with one stone.
Why is it that when you take antidepressants outside of Wellbutrin, why do you gain weight with them? Because a lot of CF patients have trouble with weight. Is it a form of an appetite stimulant, or why does that happen?
Well, it doesn't happen with all of them. So some medications actually can cause weight loss, while others can cause weight gain. It has to do with a lot of different factors. Sometimes it increases appetite, and so it's really educating yourself about the fact that you have to eat what your body needs and not eat when you feel like it all the time. Do you find that in your cystic fibrosis population that weight gain is an issue? Yeah. Yeah.
Weight gain equals FEV1, which is your chest wall. It's
Mm-hmm.
the last thing. They're so malabsorbed, it's hard for us to put weight on them. So when we select an antidepressant, we often want to move towards those that actually facilitate weight gain.
Right. Yeah. So killing two birds with one stone. So I can't really think of the antidepressants that we use on a routine basis that have a propensity necessarily to put on weight. They're pretty weight neutral.
Seems to, and,
Yeah.
is it Lexapro?
Mm-hmm.
Those two seem to help.
Yeah. Yeah, the antidepressants, without getting too technical, that we tend to use for pain management are the medications that are called serotonin norepinephrine uptake. Okay, it's getting late in the day. Serotonin norepinephrine reuptake inhibitors, SNRIs. And so those include, like I said, Savella, Cymbalta. Most definitely, if it's a primary mood disorder, the Zoloft is good. But I haven't seen it as much of an issue. But it's just really paying attention to, if you find that you're putting on weight when you've gotten put on an antidepressant, monitoring your dietary intake. And it goes back to prevention of the GI complications, is really looking at what your diet is, eating healthy food for you, and not filling it with non-beneficial calories.
You know, actually, we figured that some of the antidepressants' effect was a mood stimulatory, and they actually were more inclined to eat antidepressant treatments, and therefore they had a better outcome. So we actually enjoy when they are on that for the facilitation of bringing their weight up,
Yeah.
outside of other appetite stimulants.
Is there a question?
People can't hear your comments as you chat, just to know.
Camille, why don't you get the microphone, hon?
Sorry. Are we picking up here?
So yeah, we are. So there's a delay.
With next questions.
Okay. So muscle relaxants. So again, muscle relaxants not used chronically, but used for episodic muscle spasm. At times, maybe where patients overdo it, they're very effective. And sometimes they can be sedating, so if you have difficulty with sleep, plus minus muscle spasm, they're a nice adjuvant to use. And then I don't think I can conclude any discussion on medications without touching on opiates. So opiates we tend not to use so much in chronic disease states because there's so many side effects associated with the chronic use of opiates. Opiates are fantastic. Opiates being the medications like Vicodin, Percocet, OxyContin, oxycodone, morphine, all of these special medications that require a specific prescription that your doctors tend not to be so encouraging about your use for good reason. But they're excellent for short duration, episodic events, and surgery would be one of those. And I know that the patients with cystic fibrosis look at a life of multiple surgeries. So I don't think it's something that you should be afraid of, but just understand the limited use of it, the limited benefit that you're going to get, and use them responsibly, and use them in association with consultation with your physician. Are there any other questions about medications? I know we kind of went through that. Any questions from the audience on the use of medications?
You know, there are some concerns regarding opiate use. So our protocol at Stanford is minimal opiate use unless it's surgical intervention or some type of procedure because of the concern of developing drug tolerance, which would therefore escalate to higher requirements, especially with a lower lung function. So our goal is minimize narcotics, utilization of alternative, and trying to really find the root of what is the pain issue. And often, based on their multitude of medications, depression does play a key role in it, and really trying to find other pathways to manage their pain on a more chronic issue.
Yeah, I think that's a wonderful policy. And a personal note, Camille and I do work together at Stanford quite routinely, and we are, as a service, pain service, asked to consult on many of her patients that come in, and we respect the department's philosophy about the non-chronic use of opiates, and we seem to have pretty good outcomes, at least in the hospital. Yes?
So a question from the audience, from one of our viewers says that they got their transplant 11 days ago. And how long is Percocet okay?
So everybody is different in terms of their development of tolerance. So I unfortunately don't have a magic time for you. I would recommend that you speak with your surgeon about what would be expected in the normal healing. What I tell patients in general is that after 2 to 3 weeks, I would expect that the acute pain is beginning to resolve. And so I would see a reduction in your total opiate usage. But I think clear communication, if you don't think that you're healing or being able to reduce the amount of medications in a time that you feel is appropriate, talk to your surgeon or your primary doctor about what would be appropriate in their viewpoint and their experience of having done lung transplants or done surgeries in the past.
For that particular patient, the concern really is when we prescribe you pain medication on the day that you are leaving, we give you a typical allotted amount, thinking that that will be sufficient for you, and you would be tapering. So if you were taking one every 4 to 6 hours, and you take one every 8 hours to 12 hours to one a day to none. So you go Percocet, right, which is a Tylenol oxycodone combo, then you maybe just go to extra strength Tylenol. Then maybe you go to regular Tylenol, then maybe you don't do it at all. Or you think about, could I do some relaxation, take a hot steam shower, get a massage, other alternatives rather than narcotics. You can't drive with narcotics, and certainly I know that you're not drinking alcohol, but these are options for you, because I think part of the pain of surgery is going to take a lot longer, and it's not necessarily the best thing to be on narcotics probably any longer than you're really already slotted for, unless you're having high fevers or you're really having other respiratory problems.
A nice adjuvant to any surgery, and chest surgery in particular, would be to consider using an anti-neuropathic agent such as gabapentin or Neurontin, which I mentioned earlier. In clinical practice, the use of these medications in combination with the opiates, in combination with the Tylenol and the nonsteroidal, has been found to not only promote healing, but also has allowed patients to get off their narcotics, their opiates, sooner. So that might be something, again, if the healing process doesn't seem to be progressing as you feel it should, or you're developing new burning type pain, which again is not uncommon in thoracic surgeries, you may want to talk to your doctor about using some type of additional medication such as gabapentin or Neurontin. I hate to get pigeonholed into using specific medication names, I really do, but gabapentin is the generic name, Neurontin is the brand name, is a medication that's been out for generations. It's got a very good track record to it. It's got very low side effects, and it essentially has no interactions with other drugs. So it's a very safe medication to use, and it's a really nice adjuvant or additional medication to use when you're healing from surgery. Is there another question in the audience? No. Okay, so we're going to move on to interventions. So there's a limited amount of interventions, but there are some interventions, procedures, nerve blocks that we can do for patients with chronic pain in the cystic fibrosis population. This, again, can be used in combination with medications or instead of medications. It has a higher risk profile because you're actually doing something to a person that could potentiate a small risk of bleeding, small risk of infection in a patient population that's already compromised. But these include trigger point injections. So trigger points are those areas of muscle spasm that when you press on it radiates your pain outward. And so you can actually go in there with a small needle and local anesthetic, lidocaine, which we discussed earlier, and numb up that muscle, which allows it to move, and then you're educated about how to stretch those muscles out. So it's really for the refractory muscle spasm, or those muscle spasms that just seem to ball your muscles up in a tight knot. Nerve blocks or steroid injections. So this would be more for the patients, say, that are post-surgery. Okay, thoracotomy. It's not uncommon to have post-thoracotomy pain from... It's the incision that they make in your chest when they do a lung transplant. So when you see this type of injury to a nerve, if it occurs, you can usually localize it to a particular nerve that is a very characteristic to get injured in a surgery like this, and actually go in there under x-ray, and you can put a little local anesthetic, lidocaine, and steroid there, and reduce the firing of that nerve or the burning pain associated with that nerve. And sometimes that's all it may take, and then it reduces your need for using chronic opiates, Percocet, or chronic anti-inflammatories otherwise.
How long does that intervention last for? And does that steroid, when you inject it, impact my blood sugar since I'm a diabetic?
Absolutely. So again, you have to have full disclosure with your physicians and your surgeons whenever you go to have any type of an intervention or start any new medication. So yes, if you get any kind of a steroid injection, you have to monitor your blood sugars a lot more closely because it will definitely spike your blood sugar. Not forever, but for possibly 12 hours afterwards and up to days afterwards. And your other part of that question was?
How long does it last for?
How
this
long does
pain
it-
relief?
How long does it last for? If it's going to be effective, if the physicians have identified the exact nerve, it can be instantaneous in terms of the relief that they will feel. They'll feel it right away. It's unclear how long it will last. So in a non-diabetic, when we use steroid, you may get weeks to months of benefit. But in the pain clinic at Stanford, we use these nerve injections more as a diagnostic tool. So sometimes people get therapeutic benefit, meaning they get benefit for months and months, maybe years, and they don't need another injection until a long time down the road. But sometimes they just get a diagnostic benefit. So that would be benefit where it's really time limited, so hours to weeks. And we have more advanced procedures or interventions that we can do.
We lost audio again, sorry.
It's okay. So I can talk off record?
I did have a comment from someone online who has a 9-year-old with chronic pain. And or he was just saying that we're doing this and hoping to find something to help her. Yeah. Get audio back, if there's anything that would be specific to a young child.
Yeah, and we'll go, the next couple of slides, we'll talk about that, more of the non-medication therapies.
This is adult triggered.
Mhm.
This is really.
No, yeah.
Okay, we're back.
Welcome back. So, Camille, I think I answered your question. So these injections can be short-lived in terms of the amount of benefit patients will get. They could get it just for a short period of time. And if, in fact, people have a significant reduction in their pain for a short period of time, we have more advanced procedures that we can then go forward to do. And again, these procedures would be done really by professional providers that specialize in chronic pain management and these types of injections. So this would not be an injection that you would have done in your primary care doctor's office or in your pulmonologist's office. So during the break, there was a question from somebody in the audience regarding pain management in the young teens or under teen population. So this does not include infants or 1 to 2 year olds, but I'm going to, in the next couple of slides, talk more about pain management outside of medications, outside of interventions, with the caveat that even in the 9 to 15 age range, some of these treatments, the medications, the interventions, could be effective. But I think it's really important if these recommendations are made in a specialty facility with providers such as the Lucille Children's Hospital, Packard Children's Hospital, where they have a pain clinic devoted to the pediatric population. So complementary treatments. Camille gave us a nice segue onto these treatments earlier. So again, complementary treatments are what they state they are. They're complementary treatments. They are treatments that can be used independently or in combination with medications or with other interventions. Acupuncture is very underutilized in the adult as well as the pediatric population. There are so many ways to get acupuncture. Both by Eastern medicine practitioners or by Western medicine practitioners. And I'm going to give you my email at the end of this lecture, and if you're in the Bay Area and you're having problems with getting this paid for by your insurance, and you have an interest in it, I can give you some good avenues for low-cost acupuncture. But acupuncture is a fantastic way to manage localized pain. And is very low risk, very high yield. Acupressure, patients can be trained how to do acupressure on themselves. And it is usually best if you get trained by a practitioner that does pressure, but it's not a complicated treatment to do. And it really focuses a lot on the same philosophy as acupuncture without the needles. And that might be appealing to some people. Massage. We all don't have the good fortune to be able to afford massages, which can be quite expensive. But your family, your loved ones, your significant others, they can be trained how to do some deep tissue massages. And massage, if you can afford to pay for it, even if you're going on a monthly basis, can be really effective in reducing stress, but also reducing those chronic muscle tension spots that we talked about. Yes.
For patients on the adult side that are admitted for cystic fibrosis, you are allotted 2 free massages every single week. And the reason why we're referencing this now is some people don't know that when they come in there, but it is one of our healing avenues that many, if not most, of our patients utilize. So 2 free massages every week when you are admitted to the hospital at Stanford.
That's fantastic. I'm trying to think, how could I get admitted to Stanford Hospital to get my 2 free massages? So, all right, so some additional complementary therapies, physical therapy. So you can actually get massage through physical therapy. So patients don't realize what wealth of treatments are available actually through their physical therapist office. Physical therapy is covered most often, either unlimited or limited, by your insurance. And so you can most definitely have your practitioner write a prescription for massage, therapeutic massage, or any other treatments, and have that done at, through a physical therapist, a licensed provider. Occupational therapy, for those of you that don't know the difference between occupational therapy and physical therapy, occupational therapy really focuses more on activities of daily living, work,